look over it, and before you leave here, I want you to feel comfortable with it. And I think just about every group that's gone through this felt a lot better. So, let's look at the first page here. This one here was actually a slide in one of my Zoom classes. It goes over what's going on in the heart with where it is in the EKG tracings. And it also goes over how to calculate the heart rate. And I know we did that together in class. Basically, if you remember EKG paper, this is what the EKG paper is going to look like that comes out of monitors like this. It will be marked off in 3 second segments, so you can count the number of R waves in a 6-second strip and multiply by 10 to get the heart rate for a minute. But you guys will get to see this, and a lot of you guys are in Jess Curry's group, right? So on 5, you're in 4D, but do you still have some people on monitors at the bedside? Sometimes.
One's in a blue.
Okay. So you will see this then if you go to a different setting like cardiology, we're allowed to go there now, or ICU or ER, where you are, Fanny. So you can pass that around just to see how little the markings are. So you really have to look very closely. That's why we use these calibers. The next page is just to remind you, and this was another slide on Zoom, that you need to not just look at that monitor when you're sitting at the desk charting and say, oh, my patient's fine. You don't know, that's not going to tell me the patient fell on the floor. That's not going to tell me the patient's in chest pain. That's not going to tell me a lot of what's going on with the patient. So I need to get up and assess all these things. Are they alert and oriented? Are they confused? Are they in pain? Are they diaphoretic? What's the rest of their vital signs? What's their urine output? Are they having pain? What's their skin look like? So you want to look at all this stuff when you're looking besides these EKG tracings. So if we go to the first rhythm, normal sinus rhythm. Normal sinus rhythm is what you're seeing up here on the monitor. And when you guys are in here doing your case study, if you want some extra practice with rhythm strips, there's a whole bunch of rhythm strips here. And if you turn them over, it has what kind of rhythm it is, the PR interval and that, if you want some extra practice, that's up here. So if I look at this first strip and going along with how to read all these strips, the first thing I want to do is look at the P and the QRSs. So the P waves are the smaller upward deflections before the big QRS complexes. So I'm kind of looking, is there a P wave before every one of the QRS complexes? Do you see that? And then I'm looking at the QRS complexes. Do they all look about the same? About the same. Let's just leave it there. Is there one P wave for every QRS complex? Yep. All right, so then I'm going to measure the PR interval. So I'm going to take my calibers. I'm going to put it at the beginning of the P wave, and if you forget exactly where that is, go back to the What's My Name page. And then the beginning of the QRS complex. And I'm going to count the number of the little tiny boxes in that PR interval. So how many little tiny boxes are you counting? 4? About 4, 3 or 4 I heard. And don't worry if it's not going to be for the exam when you have to measure a PR interval. It's not going to be, is it 3 or 4? It's going to be, is it 2 or 5? So as long as you can get in the ballpark. So if there's 4 little boxes, what's my PR interval? 0.16. How'd you get 0.16? 0.04 times 4. So just, that's how you figure out the intervals. Now the QRS interval, I'm going to use my calibers again for this. I'm going to measure from the beginning of the deflection upward till it returns to, this is the isoelectric line that kind of goes across where there's no electrical movement. And I'm going to count the number of the little boxes, the 0.04 boxes in there. How many little boxes are you getting? 2. So what is my QRS interval? 0.08. Good. Is that normal? Yes. What's a normal QRS interval? Less than 0.1, 0.12, 0.12. Good. So for the exam, you need to know what the normal PR interval is, what the normal QRS interval is, and how to measure it. So we're going to do this with every rhythm in here, so you are very sick of doing it the time you leave this station. But when you see it on the exam, you'll be glad you did it. Is the rhythm regular? How do I tell if the rhythm is regular? Plot it out. Right, so I take my calibers, or if I don't have calibers, I can take my piece of paper and mark it. And I mark from R wave to R wave, and I kind of walk it out. Is it equal? Yeah. So that's telling me that the ventricular rate is regular. How do I tell if the atrial rate is regular? What part of this QR or this EKG tracing tells me what's going on in the atria?
The P wave.
P waves. So I can take my calibers and measure P wave to P wave. And what am I finding here? Is that a regular rhythm?
Yeah.
Yeah. Is everybody okay with that? There's something wrong with my P wave. Where in the heart is there a problem? Atrium. If there's something different about my QRS complex, where in the heart is there something wrong?
The ventricles.
Ventricles. So isn't that cool? You can tell all this just looking at that. All right, so to figure out the rate, I count the number of R waves in the 6-second strip, because the R waves are coming from the ventricle, and that's what's going to give me my pulse. So if this is a 6-second strip, how many R waves do you have? 8 or 9, depending. Actually, a 6-second strip would be in between these little boxes here at top, because it marks it off in 3-second intervals. But I'm not going to be this specific on the test. Is it 70 or 80? It's going to be pretty blatant. That's how you'll figure out the rate for the exam. Okay? There's a ton of different ways in AE where you count 300 boxes and multiply. Don't worry about that. If you go on and take EKG interpretation courses, you can worry about that. But for the test, that's what you need to do. Any questions about sinus rhythm? All right, the next one we're going to do is sinus tachycardia. What kind of people normally have sinus tachycardia? What patients have you taken care of that have sinus? What'd you say? COPD. COPD patients, a lot of times because they're hypoxic, their heart rate's faster. Babies, if you've been to labor and delivery or worked in pediatrics at all, their little heart rates are so fast it's hard to find all the parts because it's going so fast. When have you been sinus tachycardic?
Before an exam.
Before an exam. So if you're anxious, walking up those darn stairs, I know with a mask on, it's like a challenge. What else can you? Exercising. Good. Caffeine. If I after I'm finished with this, I'll be like nervous, right? If I'm nervous about something. What'd you say?
Sick, like with a fever.
Yeah. If you're sick, if your heart rate goes up, if your temperature goes up, your heart rate goes up. Good. All right. So sometimes it's normal. So our P's equal to QRS's. So look at my tracings and look at the P waves before the QRS complex. Do they all look about the same?
Yeah.
Is there one P wave before every QRS complex?
Yep.
Do the QRS complexes all look about the same? Okay. So the next thing I want to do is measure the PR intervals. So I take my calibers, I put them on the beginning of the P wave to the beginning of the QRS complex. I count the number of small boxes in that area, and how many little small boxes are you guys getting? 3. So 0.04 times 3 is 1, 2. Is that normal for a PR interval? Yes. What's the normal PR interval? Good. So less than 0.20. Good. So that's normal. So the atria is doing good. Ventricular QRS complex. So I'm going to measure from the beginning of the QRS complex to the end, and this is the isoelectric line here. You'll hear it referred to where there's no upward or downward deflections. So I measure my QRS complex here. And what are you guys getting? How many little boxes are you getting in the QRS complex? 2. All right, so if I have 2 little boxes, the 0.04 times 2 is 0.08. All right, so is that normal?
Yes.
Yes, because what's a normal QRS complex? Good, so less than 0.12. So is the rhythm regular? So I'm going to take my calibers and I'm going to measure R to R and kind of plot it out to see if my ventricular rate is regular. Are you getting a regular rate here?
Yeah.
Yeah. So I have a regular ventricular rate. How about an atrial rate? How would I measure that? How would I plot that out? P wave to P wave. Does it look like it's regular?
Yeah.
Yep. Good. So what is everybody okay with that so far? So rate. So I have 6-second strips. So I count the number of R waves in the 6-second strip. 12, 120. Because we count the number of R waves and multiply by 10, and that gives me the heart rate. So what'd you say? That's a good question. That's a good question, and we're going to talk about it in class this week when we talk about MIs. Sometimes that can tell you it's an elevated ST segment, and it can be different things. It can be from heart damage, injury, infarct, or ischemia. We'll talk about that. We'll look at that. And it can also tell me different things about electrolytes. I don't have time to get into all the different things that it can mean because if you take, there's so many different things, but it's so cool, and I hope you guys will love this stuff because it really is interesting. And depending on where you work, you may get more into this if you work in a cardiology office, if you work in ICU, 5D, different things like that. So what I do when I identify a person as in sinus tech, I want to assess for signs and symptoms. What kind of signs and symptoms would be concerning to you if a person was in this rhythm? Chest pain, if they're having chest pain, because what does this heart rhythm do to the myocardial oxygen demand? Increases it. So if a person just had a heart attack and they come in and their heart rate is 200, what is their myocardial oxygen demand like after it's already been injured? So we got to get that heart rate down. What else would you be concerned about it being like this?
Hemorrhage.
What'd you say?
Hemorrhage.
Hemorrhaging, good. So if a person comes back from surgery and I go in there and I take their heart rate and it's 180, I'm concerned because the heart's trying to pump the blood around because it might be leaking from somewhere. So I'm going to assess the patient. Shortness of breath, they could be hypoxic. Pardon me?
Pain.
Pain, if they're in pain. So if they're in pain, how am I going to treat it if the sinus tachycardia? Pain meds, right, I give them some pain meds. If they're hypoxic and their O2 sat is 88 and their heart rate is up, how am I going to treat it? Oxygen. If a person's anxious and their heart rate is up, how am I going to treat it? Give them some Xanax. Tell them to take some deep breaths. So the treatment for sinus tach is to look at the cause. You know, I'm not going to say treat sinus tach with oxygen or treat sinus tach with Norco or treat sinus tach with Xanax. You have to see what is causing it. Does that help you guys?
Mm-hmm.
All right. Any questions about sinus tach? The next rhythm is sinus bradycardia. And sinus bradycardia has all the characteristics of normal sinus rhythm, except it's a bradycardic rate. It's slower than what? 60. So let's start analyzing this so you guys are comfortable with going through analyzing heart rhythm. So look at the P's and the QRS's. Do they all look about the same?
Mm-hmm. Yeah.
The P waves and the QRS's? And there is a P wave before each QRS. Good. What's my PR interval? How am I going to measure that? I'm going to take my calibers, put them at the beginning of the P wave to the beginning of the QRS complex. And how many little boxes? So I got 4 little boxes. So my PR interval is 0.16. Is that normal? Yes. My QRS complexes. So I'm going to take my calibers and measure from the beginning of the QRS complex till the end. How many? 2 little boxes. So my QRS complex is 2 times 0.04, 0.08. Is that normal?
Yes.
Yes. So the rhythm, regularity. So I'm going to take my calipers or my paper if I don't have calipers, and measure from R to R and kind of plot it out, walk it out. Does that look regular to you? Is it equal?
Yeah.
So my ventricular rate is equal, so I'm going to say my pulse is regular. And you guys know when you're putting in vital signs, that's one of the things it will ask, is it regular or irregular a lot of times. My atrial rate, does that look regular? Is my P waves pretty? Walk out, okay. So the rate, how do I get the rate?
Count the
R waves in a 6-second strip, and you get how many? 5. So 5 times 10 is 50. Don't you wish all the math on the exams was this easy? So what kind of signs and symptoms do I want to check out on my patient if I see they're in this sinus bradycardia rate? What'd you say?
level of consciousness.
Level of consciousness. Are they confused? Are they alert? Respiratory rate, if they're fatigued. What'd you say? Dizziness. Are they symptomatic with feeling dizziness? Did they fall? Did they have orthostatic hypotension? Are they athletic? Very good. A lot of times we'll see very sinus bradycardic rates in very healthy young people, athletes, people that run track. If they exercise a lot, it's like exercising any muscle. Your heart is a muscle, so a lot of times it gets more efficient and it doesn't have to pump as often, so people will have resting heart rates in the 40s if they're very fit. In an 80-year-old lady that is having trouble breathing and she comes in and her heart rate is 34, I'm concerned about it. In a 21-year-old that is a track star, I'm not concerned about it. And I would assess them for symptoms to see. The 21-year-old that's a track star is going to be fine. The 80-year-old in congestive heart failure is not. They're probably going to be dizzy. Their heart rate's not going to be good. Might have some pain, shortness of breath. All right, so I'm going to look at the signs and symptoms. And how do I treat sinus bradycardia? What is my go-to drug if somebody is symptomatic and their heart rate is going down? It's in Iggy, and we talked about it in class. Atropine. Atropine is my go-to drug. If somebody's heart rate is dropping and they're symptomatic, there's usually a standing order to give them atropine. How long is atropine going to last? How long does atropine last, Fanny, in the people who use atropine to? Usually it's very quick. It's not going to last more than like an hour would be tops. You're going to see it initially go up, but then it's going to wear off, and if it decreases again, I can give them another dose of atropine, but probably there's something going on. Either they might be ditch toxic, they might have had an MI that would damage the area of the heart, it's going to make it slow. So a lot of times we'll put them on an external pacemaker. Remember we talked about that in class, where I can actually put these pads on it. They're defibrillator pads, but they can also pace. And I can hook them up to the monitor and pace them until a cardiologist can come in and do a permanent pacemaker. Permanent pacemakers are here. I showed you these on Zoom, but you can actually look at them. They're little tiny devices that are usually implanted in the subclavian area. Also, implantable cardiac defibrillators are in the same thing. They're just a little bit bigger, and some of them are even smaller now. This one does not have leads. It actually just goes in the patient's skin. The implantable cardiac defibrillators or the pacemakers, they will go in a patient's chest, and they have leads that plug in here that we actually insert into the heart muscle. So think about what we talked about in class. What do you worry about if you're inserting leads into the heart muscle? What thing can happen? Pardon me? Infection. I'm cutting the skin, and then I'm introducing something into the heart muscle. And what other thing did we talk about that can happen if I could possibly puncture that muscle?
Cardiac tamponade.
Cardiac tamponade, very good. Because I can actually go through all those layers, and then I can bleed out into the pericardial sac. So the two big things we worry about with implantable cardiac defibrillators or pacemakers is infection and cardiac tamponade. Okay? So I'll pass these around if you guys haven't gotten a chance to see those. Now I lost my pen. Did I leave it up there? Thank you so much. All right. So those are the treatments we're going to see. Any questions about that? You guys okay with sinus bradycardia? Isn't this fun? I love doing cardiac. I could talk about cardiac stuff all day. All right, so the next rhythm is a fun rhythm, atrial fib. This is the most common heart rhythm that you see, especially in the elderly people. It's very easy to identify once you know the criteria. If you are on 5D or in ER or ICU or cardiology, there's certain things you'll see and we'll talk about that you can kind of look at it and say, oh yeah, that's atrial fib. So let's analyze this rhythm so we're comfortable with it. So are there P waves? Do you see P waves on this tracing? No. So that's the first way to identify atrial fib, no P waves. Are there QRS complexes?
Yes.
Yeah. Do the QRS complexes look normal? Well, they're irregular, but can I measure a PR interval? No, because there's no P waves, so how can I measure that? Can I measure the QRS interval on these? Yeah. So take my calipers, measure from where it begins to where it ends. Now this EKG tracing has inverted T waves that we have not gotten to yet. How many little boxes do I have in the QRS complexes? One. So what would it be, 1 or 2? So if it was 1, it would be, what is my QRS complex? 0.04. If it was 2, is that within normal limits? Yeah. So if my QRS complex is normal, this is critical thinking now, where is the irritable focus coming from? The atria or the ventria? The atria. Because how do you know it's coming from the atria? Because there's no P waves and the QRS complex is normal. Isn't that cool? You can figure that out just from looking at that. So that's how I can tell it's from the atria, because the QRS complex is within the normal duration. So is it regular? No, I try to plot that out. It doesn't plot out at all. That's my other cue. It's irregular. So there's no P waves. The QRS is within the normal limits, and it's irregular. Okay, so those are the big things you look for. If you see this rhythm on the test, you can kind of look at that and think, okay, that's what we talked about. What's the rate here? How do I know what the rate is? The R waves, right? I can't really tell an atrial rate because it's so fast. I think your textbook says 200 to 600. But I'm not going to make you do that. Just the ventricular rate. What are you getting for a ventricular rate? 70. So is that within normal limits? Yeah. So the rate is 70. What do I want to assess about a person if they come in and I hook them up to monitor and I see they're in this rhythm? What are things that I want to assess? Good. So if they're short of breath, are they having chest pain, chest palpitations? What's their blood pressure? Some people are able to tolerate rapid rates for a short period of time. Usually with atrial fib, if we can get the ventricular response rate down to normal, between 60 and 100, people will live with this for years and years and years. And it's the most common heart rhythm to be in besides normal sinus rhythm. So if the big thing is getting people, checking if they're symptomatic, and then I would treat it by slowing down the rate. What kind of meds did you guys learn about that will slow down the what? DIG, right. So a lot of people in atrial fib are on DIG. What other meds slow down the heart rate? Beta blockers, ACE inhibitors. These are all the meds you want to take the heart rate before you give it, because I don't want to slow it down too much. So we're going to treat it by giving them meds to keep it in a controlled rate. Also, think about atrial fib. So my atria is fibrillating 300 to 600 times a minute. My ventricles are responding, hopefully at a controlled rate between 60 and 100. My atria is never pumping out all the blood in it. So blood's kind of sitting around because it's not a organized contraction. It's just quickly fibrillating. It doesn't give me enough fill there to push it all into the ventricles. So the blood's kind of sitting around in the atria. What am I worried about is going to happen with my patient that's atria is fibrillating? Clots. So what medicine do I usually see people in atrial fib on? Anticoagulants. These are the elderly people that are on Eliquis, Prandia, Coumadin, not used so much, but still you'll see some people on it. So people in this rhythm should be on an anticoagulant because they're going to throw a clot a lot of times if they aren't. One of the things you'll see happen in your practice is people in atrial fib a lot of times go for cardiac tests. They'll have echocardiograms, they'll have cardiac caths, because the cardiologist knows something's going on with their heart, and they want to see what's going on. Is it improving? Is it getting worse? Is the valves okay? So before I do a cardiac cath, where the cardiologist is going to slice my femoral artery, thread a catheter up there, and somebody's on anticoagulants, what do I want to do? Stop them. Usually, elderly people are off their anticoagulants for at least 4 days before they have a cardiac cath or some type of invasive procedure. So as a nurse, what do I worry about if I know my patient's in atrial fib and I'm telling them to stop taking their anticoagulants for 4 days? Blood clots. So I have seen people throw clots, have strokes, MIs, PEs in the time they're waiting to get their caths done. So be alert for that. Another thing too that I've seen happen, I used to work in the cath lab for years, and one of the first things we have to do, and you do this all the time, Penny, is reconcile their meds. You know, what meds are you taking? When's the last time you took this dose? And so many elderly people, when was the last time you took your Eliquis? Well, this morning. Well, didn't you get called by the nurse to stop taking this 4 days ago? Well, yeah, but my doctor told me never to stop taking this med. So you always have to check if you're getting a patient in for an invasive procedure. Think about what they're going to do. If they took their Eliquis this morning, can I do a cardiac cath safely? No. So I would then have to reschedule them. And the poor things, they're there, they're all ready, they got their ride, and we can't do it because they took their Eliquis. All right, any questions about that? Yeah.
Would you call this one quadrigeminy too? Right? Because it's missing looks like maybe every fourth one. Is that how that works?
No, not really, because it would be a different looking beat. These are just irregular beats.
Okay.
There's just kind of a longer pause after that.
Yeah.
Any other questions about atrial fib? Okay, the next rhythm I'm not going to get into in a lot of depth, but a lot of times these go hand in hand. Atrial flutter. You can actually, in this rhythm, see the P waves. There's so many P waves. So if I were to count them, I could get a number of P waves. But what happens is it takes a lot of the P waves to get the ventricles to respond. So you'll hear flutter, atrial fib flutter. Some people go between atrial fib, atrial flutter. This is more, we can get more of the blood out of one area into the other area, but it takes more times for the P wave to fire to get the ventricles filled. But you'll see people go in and out of both of these. Just so you know, it's not the same thing. It's still, the P waves are crazy. There's a ton of them, but you can see them better on this EKG tracing. But I can still tell that it's something in the atria because my QRS complexes are normal. All right? All right, this next rhythm here, PVCs. This is what you were talking about, I think. This is where I have an underlying rhythm, but I have an early beat. And I can have quadrigeminy, bigeminy, trigeminy, depending on how often it happens. So let's look at this strip. Are there P waves? Do you see P waves? How about QRS complexes?
Yeah.
Can I measure a PR interval? Yeah, in some of them. When you see ectopic beats, we always have an underlying rhythm. So in the underlying rhythm, I can measure it. So let's measure the PR interval. What do you get here in these beats that look pretty regular? How many little boxes are you getting? 4. So what's my PR interval? 0.16. Good. Can I measure the QRS in the ones that look normal, not the different ones?
Yeah.
Yeah. How many little boxes are you getting there? 1. So what is my QRS interval? 0.04. Is the rhythm regular? This is where we can tell if we're having different ectopic beats. So I get my calibers, and here it's regular. This beat here, is it early or late?
It's
Early. It comes early. In the cardiac world, anything that's early is called premature. So it's regular here, but this is another early or premature beat. What is the rate? How do I know the rate? I count the number of R waves in a 6-second strip, right? So what are you getting? 60. With this, I would want to see if they're perfusing with it. I'd feel if they had a pulse and listen if they had a pulse, if they had an apical pulse with this. So when I'm looking at this rhythm, this is premature. I need to figure out where is this extra beat or premature beat coming from. So you'll see either premature ventricular contractions or premature atrial contractions. How do I tell the difference between if the premature beat is coming from the ventricle or the atria?
The wave.
The QRS complex. Because the QRS measures, it's coming from where? Ventricles. So if my QRS complex was normal and it was premature, where is it coming from?
The atria.
Atria. So that would be a PAC. If my QRS is abnormal, where is the premature beat coming from?
The ventricles.
Ventricles. Do you guys understand? Isn't that cool? You can figure that out from looking at this. So if I know it's coming from the ventricles, because I would measure the QRS complex from this isoelectric line. So the beginning of the QRS to the end of the QRS. And how many little boxes do you got? Eight? Maybe you get 8, 9 little boxes? What is a normal QRS complex? Less than what? 0.13. Is this more than 3? So it's telling me it's coming from the ventricles because it's wider. There's some kind of delay or defect in the ventricle. Yeah. It would be from here to here.
Wait, can you go over that part again? I'm confused.
Where exactly are we measuring?
I'm measuring
From
the
the
regular
beginning
one.
of the downward deflection till it gets back to the isoelectric line, from there to there. So it's very wide, very bizarre. PVCs are known for being wide and bizarre. And I wish we had more time because I find this so fascinating. You could get into telling if it's in the same place in the ventricles, if they all look alike. If they look different, there's different places in the ventricles. Did you have a question?
Yeah, so to count the rate on this one, you're not counting the PVCs.
Very
Just
good
counting-
question, because I would count it if I was looking at the monitor and taking Marissa's pulse and I felt it. You'd feel it. Has anybody ever felt someone with PVCs?
No.
You can feel it if they perfuse, and if they perfuse, you would count it.
Okay.
So you can
So,
feel
like-
it in the pulse.
Yes.
You count it.
Sometimes you can, sometimes they perfuse, sometimes they don't.
Okay.
They're more dangerous if they don't.
Okay.
What if we just had this strip? Like, would it ask that on the test? How would we count it then?
You would just be able to see what a PVC looked. You'd be able to see that it's premature and if it was wide or.
Right, and we don't count it for the rate though?
I'm not gonna
Like,
ask
if we
you
just
that
have the
question,
strip, okay,
because
that's
it's
fair
kind
too.
of way more complex than what we're getting into
Yeah,
here.
that works.
And this, what you were asking before, how often is this beat occurring?
Yeah.
Every how many beats?
Third.
Third. So what would that be called? Try. Good. Try, Jenny. A PAC. I don't have one in here. It's in your book. It looks exactly like the QRS complex. It's just premature. Okay? All right. Any questions about this? What would I do to treat? Does anybody in here know that they have PVCs or what patients would feel like? Signs and symptoms you might assess for?
It kind of feels like you have to cough sometimes, like
Yeah.
for no reason.
So you just kind of have like a little jump, a
Yep.
skip?
Yep.
I've had people say they feel like their heart rate just stopped for a minute if they're not perfusing. Sometimes this will happen to people if you drink a lot of coffee, if you're really anxious, if your oxygen saturation gets low. Remember we talked about potassium levels are so important. If your potassium level is off, a lot of times people will throw a lot of PVCs. So we'll give them K riders. Potassium kind of boluses in little mini bags over 2 hours. So that's some of the stuff that you'll want to assess. Any questions about that? All right, this next rhythm is very easy to identify. Not a good rhythm to see on your patient. This is asystole. So, can you see any P's or QRS's? No. So you can't measure any of the intervals or check for regularity. There's no rate to count because the heart is not beating. It's gone. It's stopped beating, basically. Asystole, just like afebrile, no heart rate, no heartbeat. Signs and symptoms that you would assess is the patient's not breathing. They have no pulse. They have no blood pressure. They're not responding to you. This is like the terminal heart rhythm that we see that means the person is dead. The flat line, yes. You will see this rhythm on your patients if they become disconnected from the monitor. And it's very scary for the patients and family because all of a sudden the alarm starts sounding in the room and they look up and pretty much everybody knows that that doesn't look like an awesome rhythm to be having. And the alarms are going off and the family comes running out, oh my gosh, somebody get in here, something's happening to my loved one. And you go in there and their leads came off or they got up and walked to the bathroom and didn't disconnect themselves. So always assess your patient with this rhythm. And if you get into advanced things, you'll check it in a couple different leads. Hopefully it's in a very fine VF, but I'm not going to get into that because it's not going to make any sense to you guys. Not a good rhythm. All right, and I think we are almost ready to change, but I'll just quickly go over. The next rhythm is T, I think you guys have. Big thing to assess when you have a patient in VT is if they have a pulse or not with VT. VT with a pulse is treated very differently than VT without a pulse. VT without a pulse is on the very last page. We treat VT without a pulse like we would treat VF. So VT with a pulse, we're going to assess the person if they have a pulse. We're going to assess them if they're in pain, if they're hypoxic, what's going on with them. We're going to get vitals on them, probably an EKG if they're alert, their blood pressure's okay. People can tolerate this for a short period of time, but a lot of times what will happen is this is a preliminary rhythm to going into VF. So we want to quick like a bunny, get the doctor in there. A lot of times they'll try to cardiovert them. Remember the difference between cardioversion and defibrillation? We're going to mark the R waves, and you can definitely see the R waves on the top of this. And they'll shock them at that time to hopefully get their heart back into a more normal rhythm. Whereas if they don't have a pulse with ventricular fibrillation, this is a shockable rhythm where we use the defibrillators. So you remember when you guys took BLS and you had the AED and they're analyzing the rhythm? This is the rhythm the AED is looking for because it can shock them. You don't see that with the AED, but this is the rhythm that it would just defibrillate. It doesn't matter where in the cardiac cycle it's shocking them, it's just going to shock them. You can't, we're not even going to go through trying. Yeah, it's just the ventricles are fibrillating. Just like an atrial fib, the ventricles are fibrillating, but there's no cardiac output because it's not having an organized pump. Yes?
So if